So what we've done in the previous panels is, there's been kind of an agenda to get through with the speakers. There is here too, but it's more fluid and issues arise as we go. And what I sometimes do is, if you've got a comment to make that's on message at that time, raise your hand and I'll try and bring you in, rather than cramming everybody into the last 5 or 10 minutes. So, if you've got a comment to make or you disagree with something, or you've got a point to make, raise your hand and I'm happy to have that conversation as we go in a much more fluid way in the whole of room. Karen, do you want to just talk a little bit about your journey as a health consumer, where it came from, what drove you, and what messages you take for the room here?
Sure. So my, journey as a health consumer or health consumer representative started in 1996 when I was implanted with a mechanical heart valve which was faulty. I had 2 strokes, infarct, kidney and spleen, and a year later they took that valve out and replaced it with a tissue valve. And at that point, I started to become involved in the regulatory system and just looking at what are the safety guards there for consumers when a device fails. And what I found was that the Therapeutic Goods Administration, the ones who are supposed to keep us safe with devices, whilst they have very rigorous legislation, their administration of that legislation was very poor. It later led to a Senate inquiry into the TGA and a full review of the TGA. From my own personal experience, so I now have had 5 open heart surgeries, 4 of them were valve replacements, and 12 weeks ago I had a heart transplant. And from my experience, I think what is missing or what would help to solve the issue for consumers is more and better information. And that partly is about information sharing within the system, and partly that is about just getting the right information together. There's still, to the very basic thing of informed consent, there is inadequate information to give most people a proper informed consent. And that's not necessarily because the information isn't there. That's because we do the research, we have the numbers, but it doesn't filter through to the clinicians who are actually interfacing with the patients. And there are very poor pathways for the patients to get that information in other ways. So across all of those experiences, some good, some bad, and as Chris was saying, some ugly, I think that the one thing that could help is better information. So that's better information for patient consent, for clinical practice, better information for research. And when I say better information for research, I'm not talking about more research. I'm talking about research organisations putting their information out there in innovative ways that are more effective, and also sharing information so that we know who is doing what, so that research isn't duplicated and that it gets across to the coalface. And then we need to be sharing information with the regulators so that we're making the regulators do their job.
So just go to informed consent for a moment. You're presumably not just talking about surgery.
Not talking about surgery. Virtually every interaction where there's treatment needs to be at least some informed consent. The model that I've promoted has been the 3 questions to ask your doctor, and that is, the first question is, what are my treatment options? The second question is, what are the expected outcomes? And that needs to include side effects or complications. And the third question is, how likely are those outcomes to occur to me, both success and complications? And those 3 questions apply really to every single treatment, whether you're getting a medication, whether you're deciding what contraceptive to use. It pretty much covers all of the information that patients need. When I talk to doctors about those 3 questions, the most common comment that I get is, we don't have that information. And my answer to the doctors is, if you don't have that information, how are you treating your patients? Are you really treating them blind? And then you tease out the fact that, there's no hard evidence, but they've been doing this for 20 years. And that on its own is at least some evidence. That's what you should be saying to the patient. And if there truly isn't any information, then that's what you need to tell the patient, that I recommend this treatment, but there's no evidence to support it.
Coming to the point I made earlier about patient-centred care, What does that mean to you?
Patient-centred care to me is thinking about how you organise your services from the perspective of the patient. One of the things that I'm having at the moment with the follow-up for the heart transplant is you attend the hospital and you attend a whole lot of clinics. And I have to say, I've had a really good run with the clinics and no problems, but there are patients that have to travel for 3 hours to get to the clinics. And then they sit there, they have doctor's appointments booked when I know all the doctors are in a meeting and there's actually no doctors available. And I'm lucky because I live 10 minutes from the hospital, but when you have to drive for 3 hours and then sit in a clinic for 4 or 5 hours to get your doctor's appointment and then drive another 3 hours and you've had a heart or lung transplant, I mean, those are really hard-going things. And I just can't believe that there isn't better ways of organising it if people actually thought from the patient's perspective.
You spend a lot of time with organisations, with doctors and others planning better ways. How receptive are those ideas, or have we still got old thinking?
Look, I think at face value, everybody wants to be patient-centred. I very rarely come across a doctor who goes, oh, who cares? Everyone wants to be patient-centred. The problem comes when we actually come to how we organise services. The most efficient way, financially, of organising services is not patient-centred, it's clinician-centred, it's health service-centred. And, I know that our healthcare dollars are precious, and therefore we have to find some form of compromise between those things. But I could go into, healthcare services now and fix up probably 40% of the problems without any extra money. So a lot of them are just changing the way that you think, changing the way that you work, the same way that other industries have had to modify the way that they work. Health talks the talk but doesn't walk the walk. They don't actually make the changes. So I guess I've been a consumer advocate now for 12 years, and I guess one of the hard things is that you find yourself having the same conversations over and over and over, and nothing actually changes, even though everyone in the room, everyone on the committee, all the way up to the minister agrees with you. The changes just don't happen.
So I still hear people saying, oh yeah, but what's a consumer anyway? How do we know that they're representative? I still hear people saying, what's a consumer anyway, and how do I know the person I'm going to invite onto this committee is a real consumer?
Sure. Look, the thing I say to people from my time as chair of Consumers Health Forum, and if you're thinking about having a consumer onto a committee or an advisory body that you've got, you need to be sure you're getting the right type of consumer. So we generally divide it into the public. So, let's start first with the community. So the community is, their objective is to have good services in their own community. You have the patient, and a patient's objective is to maximise their own health outcome. So a patient is a person who's currently interfacing with the healthcare system, and they want their health outcome to be the best. A consumer is someone who has in the past or will in the future interface with the healthcare system, and a consumer's objective is to have the best healthcare system that they can have. The public is the funder and also holds the social and moral conscience of the healthcare system. And then, as I said, the community wants best services for their community. So you need to look at what it is that you need consumer advice about and make sure that you're getting the right person. So if you're designing a outpatients clinic at a hospital, you need a patient advocate. So it's really the patient experience that you need involved there. If you're looking at how you do privacy in a healthcare service, then you're really looking for a consumer representative. If you're planning on opening or closing a healthcare service within a community, then you need community representatives. And if you get that wrong, if what you wanted was a consumer representative and you get a patient advocate, what you'll end up with is someone who wants to talk about their hip surgery when what you want to talk about is system issues. So it's really important to identify what your objectives are and then get the right representative.
Jane, your experience and with advocacy started with your husband's dementia. Do you want to tell us a little bit about that?
Sorry?
Sorry, it's very
hard
hard
to hear,
for...
yeah.
Can we just get these fallback speakers working a bit better?
He's got the echoey.
So your experience started with your husband's dementia. Do you just want to tell us a little bit about that?
Yeah, well, the only reason I'm here today is because my husband had Alzheimer's disease, which he was a senior research scientist with CSIRO, and at 69 he was diagnosed with Alzheimer's disease. It was a very rapidly progressing form of the disease, and he died in less than 4 years. So I was not the patient in this case, I became his carer. And for me, that was an absolutely agonising, painful and frightening process in lots of ways. Joyce Carol Oates described in one of her books the experience of someone she knew whose husband had Alzheimer's disease, and she described it as losing her husband by slow, excruciating degrees, and that really resonated with me. So I felt that I was thrown into a completely foreign territory, which I had no roadmap, and I didn't know the language, because I knew very little about Alzheimer's disease, and I certainly hadn't expected to happen to me. My husband was 14 years older than I was, but I hadn't expected that to happen at my time of life, nor at his time of life. And of course, I know a lot more now. So it was a very difficult process. Our youngest child was still at school at the time. So I think that the hardest thing was that there is no treatment. There was nothing that we could do to cure the disease. So basically, you're just preparing for death. I didn't really expect death to come so quickly, and I was very ill prepared for that, I think. So I think that one of the things that I found really difficult was navigating my way through the system. So I think the sorts of things that would really help would be having what is referred to sometimes as a key worker, or someone to help you navigate through the system. I had to do all the navigating myself because my husband didn't have the capacity to do that, so I had to make decisions for him on his behalf, which was often really very difficult because I was still trying to work and I had to fit it in around what I needed to do. So I actually did become a patient, I suppose, along the way, because I did have to access counselling, which was very helpful for me. And one of the things that I was advised to do by the counsellor was, she said, hang on to something which is yours, which was really very helpful advice for me. So I did have I managed to sort of hang in there doing some part-time work. The other advice I was given was access every form of help that you can possibly get because you're going to need it, and that was very sound advice too.
But you have to find it for yourself.
You have to find it for yourself, and you find one thing and that works for a while, and then you're told, I'm sorry, this service is no longer suitable for your husband, and I say, well, what do I do now? Oh, well, you'll have to go and find somewhere else, and so you're floundering a bit.
So an individual service might put you at the centre or try hard to, but you weren't in the centre of the system.
It's centre of the system, and you don't have some central sort of point where you can go to say, okay, well, this is where we've got to now. It would have been really helpful to have some sort of roadmap as to where we were likely to be going next. I know it's a very unpredictable disease, so it's going to be different for every individual going through it, but to have a central point of contact, somebody to just help you negotiate the system.
What I've heard some specialists say, well, that's the job of the GP.
Yes. Well,
This is a room for honest conversation.
Yeah. So, I mean, my GP was very helpful, but he didn't really... We moved on to seeing a psychogeriatric specialist who was helpful in terms of providing the treatments, but didn't necessarily help in finding the services. The most helpful thing in finding the services was actually belonging to a support group which Alzheimer's Australia set up for younger women caring for a partner with dementia, and we all started it together at the same time when we had husbands who had dementia, and so that was the sort of, by word of mouth, we were able to actually learn about what were good services to access.
So just give me the selection criteria for a navigator.
A navigator. Well, I think
They're used to bureaucratic language here.
Yeah, okay. So the navigator, I guess, would be someone who would have to provide the sorts of services you might expect from a counsellor, so sympathetic, understanding person who you can talk to and who understands what your
Okay, a
needs
surgeon.
are.
All right, carry on. Yeah.
He said a surgeon.
Cheap shot.
Someone who understands the system out there and all the services that are available for you to access. And of course, the services have to be there, that's the other thing. I mean, respite was an issue which I constantly came up against, finding appropriate respite. But so they need to know the system, but the system also needs to have the types of services that you want, so that's a bit of an issue. What else?
So this isn't Nobel Prize winning stuff.
No, this is very fundamental, basic, ordinary.
And there will be some services around Australia who do this, but it's not systematic and it's not there, and it's easy to do and not expensive.
Yeah, we did have a key worker program which Alzheimer's Australia ran for people with younger onset dementia, and that's, as I understand it, was a very successful program, but it didn't get continued funding as far as I'm aware, and it wasn't made available more broadly than for people with younger onset dementia, which is people under the age of 65.
Now, this afternoon we're going to extend this conversation. We are going to talk about the role of the consumer in research. Helena's going to talk a lot about that, I think. But you're on this panel, not this afternoon,
yes.
So I'm going to give you your tuppence worth now on what you've learnt about trying to place yourself within the research community and research agenda in terms of dementia and Alzheimer's disease.
Well, that was a rather an unexpected place to find myself. So in 2010, I was invited to join a network called the Consumer Dementia Research Network, which Alzheimer's Australia and the Dementia Collaborative Research Centre established because they saw the need for involving patients and the public more in dementia research. And my personal experience has been that the people that we work with, the researchers that we work with, were very, very receptive and responsive to hearing from consumers and having input, they valued the input that we were able to bring and what we were able to bring.
Did they change their behaviour?
Research. They did, I believe so.
And was this clinical research or bench or wet lab research?
Well, it can be across the board. I think that you can see the value that involving patients and the public in more care research, it's more immediate. But we can also be involved at different stages of the research process, so setting research priorities and finding a cure would be the best outcome we could possibly have for something like Alzheimer's disease. So the basic science research
How do you respond to the molecular biologist who says, what do you know about what we do? How dare you, they'll be thinking to themselves, how dare you tell me that I shouldn't be looking at molecule X, I should be looking at molecule Y, which is indeed what some consumers do.
Yeah. Well, I think that it's a two-way street. So I think we have to be respectful of the expertise of the scientists, but they also need to recognise that most of the research is publicly funded, and so we have to make decisions about what type of research gets funded. I think it's imperative that researchers are able to explain in plain language what their research is about and why it is important. And I think then we should jointly be making decisions about what sort of research should get funded. So I think there's a place, but it's a different type of relationship you might have in basic science research versus the care research area.
And in your experience of getting involved on both sides in terms of consumer involvement, so you've just explained that in research you don't feel it's token. Do you feel it's token when you come to interacting with health services, that they feel they've got to engage with consumers? So what I hear about consumers, Karen can talk about this, I'm sure others can as well, is that sometimes it's really token. It's just to tick the box that we've had a consumer at the table. Yeah,
I think in some cases, I think there are pockets of where it's being done well, and there are, I don't think it's deeply embedded within the research culture to involve patients and the public in research. So we don't have the sorts of systems, for instance, that they have in the UK, where all NHS-funded research has to demonstrate that they have some sort of patient and public involvement. We have the Involve organisation in the UK, which helps people to do that. So I don't think it's deeply embedded within the research culture. The NHMRC statement is rather weak. It says something like researchers should consider the value of including They talk about consumers in their research. So it's not, nobody has to do it. So there is a bit of a ticker box element in some cases, yeah.
Mark, doctor as consumer. You've been to hell and back. Well, not that anybody else in the program, everybody's been to hell and back on this panel, but yeah.
Yeah. Well,
just tell us your story.
Well, about 2.5 years ago, I became unwell very suddenly, and I might add that as a neurologist professor, as a haematologist, Professor Levi makes an excellent neurologist, because I did have some symptoms, and I said to Chris, "Oh, I'm not feeling very well," and he said, "Oh, you're just getting old." About 2 weeks later, I was in intensive care, ventilated, but you know that's by and by. But it was an incredibly difficult experience, and I mean, obviously everyone on the panels had the same situation of feeling. You know, I felt incredibly powerless and frustrated, and I guess one of the things that my experience might be a bit different to the others is that both in Newcastle and Sydney I was cared for by staff who I'd worked with for many years, so that was incredibly difficult for me, but also for them, I think. So, you know, I was in intensive care and I'd have all of my body functions attended to by nurses and wardsmen who I'd, you know, been friends with for a long time, so it was really a really difficult experience. But as time went on and I recovered a bit, I mean, I had ups and downs, I guess there are a few things that I reflected upon as a patient that I might have probably been able to do better as a doctor, and particularly I spent a lot of time in the ward, which I felt like as a prisoner most of the time, but during that time I spent a lot of time talking to the other patients who obviously didn't have a medical background, and it was very interesting to hear their perspective on their care and what they'd been told by the medical team in particular.
Tell us what you heard.
And
so tell us what you heard.
Oh, well, for example, you know, there were, you know, the disease I've had, leukemia, was, you know, obviously a particularly nasty one and has quite a high mortality rate. And it was pretty clear to me that a lot of the patients that were on the ward at the same time as me had a bone marrow transplant, and their prospects of survival were very slim, but that was clearly not the information that they'd at least taken on board from their medical team. I'm sure that, and having reflected on my conversations with patients over the years, I know that generally each time you have a conversation, the patient and family might only take away 10% of what you've actually said. So it's very important to, I guess, try and get the patient and family to try and repeat back what you've said to them and to see if they've understood. But I could see it was very clear from the patients that I was an inpatient with on the wards that they really had very limited understanding of their disease and their prognosis. And that was really difficult for me because they knew I was a doctor and they asked me for my opinion, and obviously I'm not an expert in haematology. So it was very difficult to know how much to say to them because I knew that their prognosis was...
So what about your own care? Did things surprise you about what happened to you?
Yes and no. I mean, I guess again because the staff that looked after me knew me, I probably had a bit of an armchair ride, but I can tell you it didn't feel like an armchair ride. It was incredibly... It was an awful experience. And there were times when, and for example, my regular haematologist, when he was away, there would be another one who I didn't know so well. So I actually had someone look after me who was a personal friend who we trained together. But when he was away, there was another haematologist came and see me every day, and he'd stand at the end of the bed and go, and so, not say much else. And that made me think, gee, something really bad's happening here. And I found out later that he did that with every patient, and they were all terrified.
There is something about the way haematologists communicate, I think. They go to special haematology school, I think. Yeah.
Yeah. So I think I guess I've reflected back and thought again. Also, I like the concept of a navigator to help patients and their families through the system. The question is, who is best placed to do that. Often the person that's particularly in the inpatient situation that's tasked with doing that is a junior medical doctor who has often less knowledge than the patient and the families of their condition. And it's not really fair on anybody. Then we say, well, should it be a more senior medical person? Well, yes, but of course they're incredibly busy and...
But a transplantation nurse would have great knowledge.
Exactly. So that was my next point, that in general, at least for most inpatient services and probably outpatient services, expert nurse coordinators are the ones that should be the navigator. And there are good examples of that. For example, the Breast Cancer Network, which is, a lot of that's been funded from, for example, the Jane McGrath Foundation. But the transplant nurses, yes, they are very good.
And what about the system itself? If you were to do a redesign, what would you do?
Well,
from your own
I
experience?
think as we've heard from the other panellists that the motivation from the clinicians is there and from the consumers are there. The motivation from the managers and the politicians isn't really there. That's what I would say. So unless we can demonstrate to our hospital managers...
But it's easy to say that,
it is,
but we're talking about simple stuff. It's
Yep.
hard to imagine a hospital manager who's going to argue against case management, navigation, or anything like that if the will of the clinical team is there to do it.
You would think that would be the case. See, expert nurses are costly, and in many of the hospitals I've worked, they prefer to have enrolled nurses on the job because the more senior nurses are too expensive.
Is Jerry Marr still here? No. Damn it. And have you got a comment about consumers at the core of research?
Yes, I will mention that because obviously before I was sick, I was a clinician researcher and involved in many trials. And I'd have to say that probably we didn't have a lot of consumer involvement in most of our trials. I could say from a patient's perspective now that I was approached to be involved in many trials. And in most of them, I read the information sheet and said, this is rubbish, go away. But that's, again, because I had the knowledge of the system. Most consumers or participants
let me
would
put
not
something
have
to
that.
you. 2 or 3 weeks ago on my program on the Health Report, I had a rheumatologist from South Australia who developed, I think it was CML, chronic myeloid leukemia,
Yeah.
and was turned down by 2 or 3 different hematology groups for a transplant. And he looked at the evidence and ended up going to Israel and having a transplant in Jerusalem, paid for it himself. Survived it, did well, and he was told this was going to be a disaster. And I put this on air. There were a couple of things that were more controversial about that, because he kind of felt that he deserved some special care. I'm not going to talk to you about that as a doctor, which was outrageous. However, he did make a choice about care, which the hematologists were proven wrong. Hematologists went completely apeshit with this program, saying if this person... if you had this, if all consumers demanded this sort of care, we couldn't afford it, which rings a red light, which says they're actually making decisions about care based on economics,
Correct.
not on the patient. Do you agree?
Yes, I would say that I suspect that it's a balance. For example, if someone's chance of cure with a bone marrow transplant is, say, less than 10%, then the haematologist may well make a decision, well, it's an incredibly costly procedure, so I'm not going to offer it. So it's a balance between where do you cut the probabilities. But I would say that in my situation, I made decisions about my own medical care that sometimes completely contradicted with my haematologist, and sometimes I didn't even tell him about.
We won't go into that. Thanks, Mark. Setting a bad example for you for the children.
I think the essential thing when the system starts making decisions for individual patients based on financial decisions, they need to inform the patient that that is the basis of the decision. And what we know happens now is that doctors simply say to patients, oh no, that treatment isn't viable for you, it won't work. They don't say, look, it's not economically viable for you. And so the patients think that they're not a candidate for the treatment. And that is completely immoral. it blows my mind that people are put in that position.
Harriet, tell us your story.
So I was diagnosed with Ewing sarcoma in 2012. I had lots of chemo. I had extracorporeal pelvic radiation and then reconstruction. It then metastasized in 2015, and I had lots more chemo, 2 more different kinds of chemo, and was eventually declared in remission. But I sort of have experienced the whole range of adolescent care. I'm in 2 minorities in that I'm an adolescent in the system, but I also have a very rare cancer. So we've had interesting experience navigating that. But most of what I wanted to say was we've had experience of actually having that navigator. We had a nurse practitioner who was really, really brilliant in sort of being a liaison between the doctors and between me and adolescent. But things like that are at risk, and they've had their funding almost been taken away. And I think those are the sort of things we need to push, because as you said, they're so, so helpful when you actually have that navigator that enables you to sort of get through the hospital clinic, get through, know who you're seeing the next day, and organize all your appointments. So, yeah, that was what I wanted to say. And I think this has been such an interesting experience for me, because I'm very much a product of innovation here. I mean, I've had a lung lobe taken out with the Da Vinci system. I've had a 3D pelvis put in back in May, hemi-pelvis. That was printed in the United States and designed in New Zealand. I've had 3 different chemotherapies and radiation. And yeah, I think I embody a lot of what Sphere is about at the moment.
Absolutely, in terms of innovation. So when you hear Karen and Jane, to some extent Mark, talking, it's an alien, it sounds like an alien experience, or did you experience some of what they had, or you just feel you lucked out and you got the good stuff?
So in many ways, I was very lucky in that I got the adolescent team. All of my doctors are well versed in how to communicate with adolescents. But I've also had experiences.
They grunted a lot, did they? Or
Sorry?
They grunted a lot, did they?
Yes, exactly. Yes, they were able to answer questions like, how many standard drinks can I have with this painkiller or this chemotherapy? So they were good at that sort of thing. But I've also had experiences, because I've been treated at a whole range of hospitals, because I chose to finish my HSC and then go to college in Canberra. I had to do my chemotherapy away from my family in Canberra at college. So I also had to be treated in another hospital. And through these hospitals, I've had very different experiences of how doctors communicate with adolescents. And that's made me really consider that we need to partition adolescents, both from children and from adults. Because we're in a completely different life stage. Our priorities are completely different to that of an adult and to that of a child. And you really need to factor in what we care about at that point in life.
So some people would say they already do that, but you would experience, they would say no.
I don't think they do. I mean, we're on the way to improvement, but examples, like I can give you a few examples of when, during my first chemotherapy, I was admitted to hospital. I had a week where I'd get continuous chemotherapy. And my first day, I sat down in the bed, and then a group of doctors came in and proceeded to tell the 2 beds beside me in consecutive order that they had no more treatment options, this was the end, and that they should start sort of planning their palliative care route, because I was always in palliative care wards. So I thought this was sort of like a checklist, like they were going down the beds, like I was going to then be next. So my parents came in, I was then 17, saw I was pretty much fetal on the bed, and that was when we suddenly realized that shared wards are not a good idea for adolescents. So from then on, which should be sort of obvious, I think, I don't know, from then on, we sort of had to put a sign on the door and say, please be careful with your conversations. Because while I'm under no illusions here of the future and of the prognosis for Ewing sarcoma, I mean, I was a teenager. I'm so dramatic. Like, from the point they told me, I was already planning like my funeral. Like, that's how it works. So we know what can happen, but hearing the constant reminder of what our future could be is incredibly difficult. I think it's something that can be helped and can be prevented. It's so easy. It's one of those. But the other thing I was going to say is doctors really need to be educated on the best way to communicate and what's suitable for adolescents, because I had several experiences when I was onto my third chemotherapy, and as you know, the more chemotherapies you do, the less they work, the less chance you have of it being successful. So as I got to my third chemotherapy, I went to this new doctor that was overseeing my care. As I was still at university, I had to have a new doctor, and he said to me, my parents didn't come at that point because that was the only appointment they ever didn't come to, and I sat alone in that room, and he said to me, I don't know why you're doing this treatment, because it's not going to work. You don't, if you were my patient, I would be saying that it's not a good option for you, but because I'm overseeing your treatment for another doctor, I'll do it for you. So I, as 21-year-old, just stepped out of college, came out of that room completely shell-shocked and doubting. It's a hard enough decision to say, okay, do we stop chemotherapy now after these so many years, and I just decide that this is it, or do I keep going with what could be pretty much a redundant treatment? And I understand as a doctor you need to educate people on their options and what could happen, but you also need to listen to them, and you need to realize that I've said several times, in that conversation I've said several times, yes, I understand that. I understand, I'm well versed, I know what's happening. And if you keep pushing that agenda, that then becomes traumatic. And that was one of those traumatic experiences. So I think maybe if doctors like that, and if wards had an experience of the best way to deal with adolescents, then it would make our treatment a lot easier and a lot less traumatic in terms of emotion.
So my challenge to this room is, there's people who run medical schools in this room, who have run medical schools, some very big ones. You do this structured interview stuff, which to my mind has very little evidence attached to it. You go through all this agony about choosing medical students. You have these courses on communication, and again you hear these stories. What the hell are you doing in medical schools? And to turn out, in your selection process, to turn out people who still can't necessarily, you still hear these. Now, of course, there's always going to be a distribution curve. But you're supposedly doing that to actually get better doctors at the end who can communicate better. And I'm not sure that you're turning out the goods.
And I just don't think it was, I think it was, again, like appropriateness and know your audience. I was alone in that room and I was 20 years old, and I think that situation could have been managed a lot differently.
Catriona, as a mother and carer, what's your perspective and story?
I think I'm here.
Do you want to just pull in a little bit closer to the microphone?
Yeah, I'll pull it a little bit closer. Oh, no.
Probably just pull your chair in a little bit.
It's fixed. I'll move closer to
Mountain
it.
come to Mohammed.
I am here as a carer. I was Harriet's primary carer, but I also feel I'm speaking not just for myself, but for my wider family, because though Harriet was the patient, in many ways, the whole of the family were the patients. And I would echo Harriet that we were very lucky in that we did have a navigator. She was cared for by an orthopaedic oncology team at initially RPA and now Chris O'Brien, who have all worked together, and 5 years on are still all working with Harriet together, and it feels very much like a family. But they looked after us too. For instance, Tony, the psychologist at Chris O'Brien, always says she knows when there's a medical crisis going on because she gets 4 calls from the Ling family. It's ding, 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 ding. 4 members will all ring up to say, help, we need a bit of help here. I think we were incredibly lucky too, in that the talks this morning and down the table about equality ring true, in that we were able to keep going as a family, leading our normal life, because the 2 hospitals that Harriet's been treated in, and at times this summer she spent 3 months in hospital, and for a family that's difficult, but the hospital was 12 minutes from us. It was 10 minutes from my work, it was 10 minutes from my husband's work, my other daughter's schools. So we just kept living our life around it. But not everybody has that equality. If we had lived elsewhere, access to that treatment might have been much more difficult. I think one of the other things from the holistic point of view is it does make it much easier if you are seeing a team. There's no there was always a feeling of seamlessness. In the very early days, we quite often saw the radiologist, the oncologist, and the orthopedic people all at once, all in one meeting. And though that's a lot to take in, and that's an expensive exercise as well, it gives you a feeling that you're being cared for as a patient and as a family. I think one of the points I just wanted to make was that, I've worked in a profession for all my adult life, and I've been used to dealing with professionals. But the doctor-patient or doctor-patient carer relationship is completely different to any other professional relationship, particularly when it's your child's life that, Harriet gets her dramatic streak from me, that they hold in their hands. And so the relationship of power just feels very different. And I think that's something for doctors to be aware of, that the person sitting in front of you is not that you are God, but they're just nervous about challenging you. Even something like discussing getting a second opinion felt as if somehow I was doubting these people in which I had complete faith. I have to say they were brilliant about it and said, definitely get a second opinion, encouraged us to do so. But it's just an unequal relationship, and I think sensitivity around that would help a bit, that sometimes taking that moment to check whether there are any questions, because they'll be hesitating, because they'll be thinking like me, either this is a naive question, or I sound as if I'm challenging their authority, or questioning their right to do this.
So on the navigation issue, you had this nurse practitioner, but to what extent were you in reality the navigator?
A bit. It's an interesting one. Again, it comes down to the adolescent. Harriet was 17 when she started, so she wasn't legally an adult, but she was over 16, and she was always the patient. And then she became 18 and became an adult in her own right, and the team had to walk the delicate balance between how much did they talk to us, how much did they talk to Harriet. But we were phenomenally lucky in that the oncology orthopedic team had a dedicated nurse practitioner. And so while I did navigate and advocate for Harriet in terms of working out who to see and what to do, she was invaluable in that and introducing us to other parts of the healthcare system.
Joanna?
Well, it's bringing a lot back to me, and I don't know if I can even talk about it. It's actually quite frightening again to think about some of those moments that I had and the experiences that I went through. I was thrown into the world of having a spinal cord injury 25 years ago now. I was 31 at the time. I'd just gone on a recreational skiing weekend at Thredbo and went through an area that should have been closed off and wasn't, so ended up tumbling down a mountain and hitting a tree at a high speed with my head and breaking my neck. That's C5-6 vertebrae. I'd been out in Australia for just a couple of years at that point, and so my parents came out within a few days of hearing about it. And so some of the things that you mentioned, Harriet, about it's not just my experience but family, and very much real to me, because my mother, although she was a nurse, was thrown into a very different culture, I guess. And I think that, sorry, my voice isn't very strong. I think one of the biggest things that is relevant to me from what conversations we've heard is the alienation and the disenfranchisement and the way that you're thrown into this world that you know nothing about. I'd had very little to do with hospitals and healthcare. I'd never been into hospital in my life. And suddenly I was thrown into this world which was very different from either studying or the business world that I'd known in my career. And I couldn't believe how I felt I was treated so badly, just in terms of, I think, communication and in some cases a lack of empathy.
Which is a surprise for many people to hear, because you think, well, spinal units are small, they're used to it. You'd think that if you're going to see some patient-centered good communication, you'd expect it in a spinal unit.
I think it's changed a lot. I think I'm pleased to say that the experiences I've had since, I've found that communication is better. Certainly some of the younger practitioners seem to be being taught more about communication skills because, I mean, there were rare exceptions, but there were some terrible situations that I went through. A lot of arrogance from particularly specialists that would come into the ward and start prodding you around without even introducing themselves and even telling you what they were doing, and then march out. And I'd try and sort of, in a fairly weak voice, say, can you tell me what your prognosis is or what your view is after prodding me?
So the fact there's nods around the table suggests this is also contemporary experience.
And it was like, well, that's for me to decide and to tell your consultant in due course. And young lady, you will hear about that after that. So I'd been lying for 3 months, nearly 3 months, with my head locked into a certain position in traction, staring at a wall, a ceiling, and someone was telling me, I'm not going to give you any indication of how you're doing because that's not for you to know. I wasn't used to that. It's a very different world to me. Yes, so very frightening. I've recently had to go into hospital to visit my sister who unfortunately had to go through a lung cancer treatment. And that was at the Chris O'Brien Centre, and I have to say that the difference between going to a modern, friendly facility, well, my impression only after just visiting regularly for 10 days was very, very different than the spinal ward. The spinal ward became so scary to me, and my contemporaries say the same thing, that when I subsequently went back for something that happened, which was actually a burn, and I have to say I haven't been to hospital much, but unfortunately I had a burn a couple of years later. And I was in the burns unit for a few days, and when they said, oh, there's room in the spinal unit for you to go back in there now, I was like, no, I'm happy in the burns unit. That's how scary the experience made.
So you've become an advocate, Spinal Cure Australia, and for research and so on. And so it's a similar conversation to Jane, interpolating yourself into that research environment. Talk about that experience. And
yes, so I think one of the things that I was so shocked by was the prognosis at the time of spinal cord injuries. And when I woke up from, I guess, the medication to help me cope from being flown from Threadbow, I had a doctor very close to me staring in my face saying, you do realise you will never walk again. You will never walk again. And I'm opening my eyes and thinking, why is this guy not allowing any semblance of hope into what life I had? And I obviously didn't know what that life would be at that point. And I kept asking the question, surely there could be treatments, and friends were sending me messages, and at that time the internet wasn't around, but I was getting messages from, there's this treatment and there's this going on, and I just couldn't believe that there couldn't be some sort of hope. So I helped with a neuroscientist, I'm sure some of you would know him, Professor Perry Bartlett, and a lawyer. We set up Spinal Cure Australia, and part of it was because we did believe that with neuroplasticity and with developments that were occurring, that there could be some hope. And I'm pleased to say that over time there has been a change of dogma, I guess. There is a belief that now there are treatments and there will be treatments. And one of the most exciting that's going on at the moment with the combination of what's called neuromodulation, which is stimulation of the spinal cord combined with intensive exercise rehabilitation, is finding that patients are actually getting some voluntary recovery even after the stimulation's turned off. So that offers great hope. And so 23 years of campaigning, and not just that, on stem cells as well, because obviously the stem cell treatments which are going on are also very positive now. The combination of neuromodulation, exercise and stem cell therapy, and bridging technology through tissue engineering looks to be very hopeful at possibly one day coming up with a cure. So I guess that's why I did it.
Well, I wouldn't mind your comments about how you might rate or give feedback or become more connected in the sense that Chris was asking for. You know, if you're a customer of telco, they'll do what's called the Net Promoter Score, which is, you know, out of 10, how likely would you actually be to recommend this to somebody else? And what most people don't realize is that actually for that to be significant, you've got to score a 9 or a 10. A 5 means that you're actually negative. So it's really got to be high. But that's where you've got experience. You might have tried another telco, or you might have tried another insurance company, or Myers or something like that. But healthcare, what sort of metric, Karen? I mean, is there a way of doing this? Is there a way of becoming more connected and getting that feedback loop going in terms of...
I think there is. So I think healthcare services are trying harder to get feedback. I think there still is a lot of negativity around complaints, and we need to change the whole concept of complaints to being about feedback, because generally when patients make complaints, what they want is for other patients to not have to go through whatever they went through. The issue is if you do deal with it as feedback, you need to actually take action. So just collecting feedback for the purposes of collecting feedback will annoy everybody. But if you have a process that sits behind feedback that actually analyses all of the feedback that you get and looks for ways to make changes, then you've got a very valuable loop. I have to say I'm very cynical about healthcare, that there is even the will to enter meaningfully into that sort of arrangement, given that all of the high-level strategic planning we do filters down, hits the wall, and nothing changes. So I think healthcare systems would need to change significantly to be able to take on the sophistication of a really meaningful feedback loop.
Jane?
Oh, look, I think it's... I'm just trying to think of my own experience where I did provide some feedback in a fairly difficult circumstance that I encountered. And I basically went and spoke to the particular nurse in the nursing home who had rung me a few days before to say, your husband hasn't eaten or drunk for 24 hours, we're going to transfer him to the emergency department and he needs to have a PEG tube inserted. And no one had ever talked to me about any of this. I didn't even know what a PEG tube was. And fortunately, he was transferred to emergency department, but there was a very sensible doctor there who just sat me down and said, now, what is it that your husband would want done under these circumstances? And I said, I know exactly what he would want, so that's what happened. He died within a week in hospital. But the point at which that I got really upset was when the nurse had just taken it upon herself to make this decision. But I did go back and I sat down with her and spoke to her. She wasn't particularly receptive. And she did get quite angry with me and said, don't be rude to me, please, because I was very upset about what she'd done. However, I did go along armed with the guidelines for palliative care and palliative approach to dementia care, and which they weren't aware of and hadn't had in their aged care facility. And some days later they rang me back and said, oh, well, thank you for your feedback, and as a result of your conversations we've decided that we really ought to have some sort of advanced care planning discussion with anyone at the point at which they're admitted. So they listened to me, so I think that... But
it's an unusual consumer experience, so not many consumers will walk lines, but it comes back to Karen's point about information.
Yes, so...
being available.
Yes, so I armed myself with the information and then...
Any quick comments or questions for people to make? Just raise your hand and we'll... So Chris, and then here I think Simon. So we have a microphone down here. Yep, Ian, for this time I'll let you go first. Go on. No, go on. Go on, no, just give...
I thought it was a fascinating discussion. It's really so important to hear your personal experiences, and just to add in, from my perspective, I'm someone who's trained as a medical student, been involved in health and healthcare delivery all my career, being dean of 2 medical schools and now vice chancellor of a university, but also at the same time someone who's fortunately never been personally unwell in any serious way, but has had to deal with family issues. And I can tell you that even when you're in that situation as a professor, medical school dean and doctor and surgeon, it's still totally intimidating when you get in that consultation room and you're still worried about the questions you're going to ask and are you going to offend this powerful person who's sitting in front of you. I hope you won't mind, Norman, if I just give a few more reflections. So I've got a few comments to make. One is that over the time since I was a medical student, I've seen an incredible change in the way medical students are trained. And normally you throw out the challenge, what are we doing in our medical schools? There is much, much more attention to that patient interaction and thinking about what does the patient need, being considerate, empathy, all of those things than previously. And I was at a wonderful thing at Liverpool Hospital last week where the students did an acting thing the day before they graduated. And it was amazing to see they were with great expertise dealing with the technical bits of their job, but the compassion they were showing in that exercise was way beyond anything in my career. So I do think that I don't think fundamentally that there is something wrong with doctors as a group of people. I think that they are just normal people. And the second thing I wanted to say is that I think it's the system. The system just prevents that. There's the power of the system. Doctors are too powerful. What about the rest of the health profession? What's their part of it? The way it's structured. I think it's the system that we really do need to pay attention to. And my third thing is, I love this discussion about navigators. I think this could be so powerful. I've thought for a long time, I'm frustrated that I've never done anything about it. Health advocates, I called it, but I think navigators is a better term. Someone that patients and their families can go to for advice about who are the right people to see, to support them in interpreting what's said, to encourage them to ask the questions, all of those things. I think that'd be a fantastic initiative for us to take forward. Yeah. And it won't address all the awful things that we all experience, but it might just help to change the way the system is organised and the way people think, and to give patients support they wouldn't otherwise get. Sorry to take so long.
No, thanks, Ian. Simon, and then we'll come to Chris.
Thank you so much for all your comments. Question for you, Mark, in particular. I'm a psychiatry registrar. I'm one of the deputy medical editors of the Medical Journal of Australia, and a year ago today, actually, my wife was diagnosed with stage 3B breast cancer, and our baby was 8 months old at the time, daughter was 4 years old, so a bit of a rough year. And I'm really interested as your experience as a doctor, health consumer, what do you, the previous person asked a question there, what do you think are some of the system problems that contribute to doctors being, not as free as I think they often want to be completely patient-centered, to have time with their patients, to be able to listen to, their experience? What do you think are the main things that are stopping that? Because from my own experience, from my colleagues' experience, most people are wanting to listen to patients.
Well, thanks for that question, and I'm sorry to hear about all of that. I might add that when I was diagnosed, my wife was 4 months pregnant, and my daughter, who's now 2 and a bit, was born 1 week after my first bone marrow transplant. So that was an experience as well, particularly for my wife. I was too sick to worry about it so much. But I agree with you that, in fact, most doctors and other clinicians, not just doctors, are highly motivated to spend more time and communicate better with their patients and families, but they're under intense pressure in a lot of cases. And I guess if I reflect back on for example, yes, in the outpatients clinic where even though I guess might have been considered a VIP, I would often wait 3 hours to see my specialist as well. And I could see what he was doing. He was incredibly busy. He was double booked for every time slot. And he was a really great communicator, probably much better than I am, I suspect. And because he spent so much time communicating with patients and families, he'd run way over time, and that's what had happened. And so I don't know how we directly solve that, because do we clone more people like him and her, and that's not something you can do overnight. Do we improve the efficiency of the system so that the people that are most talented at patient communication spend their time with patients, and the people like surgeons actually spend time doing surgery and don't communicate with people? Maybe we should. At least that's my opinion, because I work quite a lot with surgeons as well. So it's a difficult issue to answer very quickly.
Karen, Jane?
Just on that, I had, with the heart transplant, you have a lot of time with doctors, and I observed while I was in hospital, you're in multi-patient rooms because it's in the public system, and what actually was working quite effectively is the senior doctor would turn up and, say all the authoritative things, and then he would have 4 junior doctors with him, and clearly the patient didn't understand what they'd said, and as the senior doctor leaves the room, 3 of the junior doctors go with him, and 1 stays behind and actually explains what he said. And that actually works really, really well for patients. I saw it time and time again that the younger doctors, I think it went to what you were saying, is that the younger doctors are actually looking at the patient, understanding they didn't understand it, and giving them the extra time. I'm not sure how that affects then their job of having to follow around the senior doctor.
Add to that? You must have had a very... I would suggest the team that was looking after you were probably way outside the 95th or 5th centile, because most of at least in my experience, both as a patient, as a doctor, the junior medical staff are so consumed with paperwork, and that they actually don't have much time to spend talking with patients and families. They often don't have much knowledge about the individual patient.
This was a heart transplant,
so
it probably is
it's obviously an ideal model, but I'm not sure it's something.
Did you want to say something, Harry?
Yeah, I actually just had a bit of a funny story about communicating with surgeons. I have a chronic bone infection at the moment, and my orthopaedic surgeon, who is, of course, a breed of orthopaedic surgeons that's quite common apparently, decided that today would be the best day to do the surgery. So I told him, got a conference, speaking at this thing, really excited for it. He said, okay, we'll do it at 7 a.m. I'm going to put you, you're going to go on to general anaesthetic, then you're going to wake up around 10, okay? And then you can drive to the conference about 11. And I was like, yes, but how coherent will I be by that point after having this done?
As coherent as an orthopaedic surgeon.
Yes, yeah. Possibly slightly less than this, if you can imagine. But I would have been much more fun, possibly. But yeah, it was, and it took a little bit to convince him that actually my priorities were slightly different to his. So yes, luckily I am here, not under general anaesthetic, but here. No, I don't need those.
Yeah, Jane?
Just briefly, I think that's one of the roles that the so-called navigator that we're talking about could actually take on in helping to communicate, someone to talk to.
Which goes back to a nurse practitioner.
Somebody and there are models, especially in dementia, there's an excellent model which they use in the UK. They're called Admiral nurses, and it sounds a bit militaristic. They're actually named after a patient who was an admiral who was a dementia patient, and they do exactly that sort of role. So there are models there we can adopt and follow.
Thank you. We'll take 2 more comments here, and sorry, Chris?
Norman, to all on the panel, but particularly Karen, and I think probably Mark, we don't have many levers here. One of the problems we have is we're talking a little bit about behaviour change here and systems change, and I was recently debating a US colleague, and I was able to go on the web and have a look at him, and he was ranked in the top 100 doctors in Los Angeles. Now, he may have had to pay for that. I'm not quite sure how that works in the States, but it gets me to the point of the patient-reported experience measure wave that's coming. And can you comment on whether actually, putting up how well the doctor addresses the aesthetics of care is likely to make a difference here? And can we develop league tables of,
So the TripAdvisor.
TripAdvisor.
Certainly, there is a role for patient experience reports, I think, for organisations like the Safety and Quality Commission, because I think that they can analyse and act on those reports. Yeah. In terms of being a TripAdvisor, I myself, a lot of consumers support it. So I have to say that I'm probably against the tide. There is quite a strong demand for it. If you look at the issues, the challenges of supply and demand in a healthcare system where we have a finite number of dollars and we have demand that really exceeds already, at least equals, if not exceeds those dollars, I think adding something like a TripAdvisor type patient experience, what you're going to get is a whole lot of people flocking to, at the moment, the system, well, look, maybe I'm being naive, but the system seems to match patient need with doctor experience reasonably well. So patients who have very complex healthcare tend to get doctors, specialists who are good at managing the complexity.
But what if you had published their 30-day readmission rates for an endocrinologist, their level of diabetes control on average in their patient group? In other words, you saw the data on their performance rather than maybe something less of their non-technical skills.
Yeah, the trouble is that how you interpret that and whether or not you then get clustering of patients inappropriately around the best specialist. So patients won't say, oh look, my need is only moderate, therefore I'll see someone who's a reasonable performer but not who's excellent. If I stub my big toe, I want the guy who's excellent. And so I'm not sure that it's helpful in matching supply and demand. And it's potentially negative.
Can I throw something? Oh.
Yes,
I was going to say the TripAdvisor model has been suggested in relation to rating residential aged care. We haven't touched on that, but that's a whole other area which really needs complete rethinking, because a lot of people with dementia will end up in residential aged care because it becomes just too difficult to be cared for at home. And so finding a residential aged care facility which is going to be the right place for the right person is quite a challenge, and we're building all sorts of facilities now which are not really ideal. We have lots of models which we'll be following, but the TripAdvisor suggestion there I think is probably quite a valuable one.
Mark?
Yeah.
I think consumers would respond rather than hard outcomes like you mentioned, which are, as you know, are not so hard because you can fiddle them any way you like, but I think people would respond more to what's the communication skills like, but also in terms of currently in the hospital system, there's usually a consumer liaison officer or whatever, different names in different hospitals who do feed back to the staff if there's been some suggestions for improvement, but generally, at least from my experience, the medical staff don't listen much to that person because they're not considered like a true colleague. So you really need somebody who the clinician respects to feed back to them. And I think in most cases when that happens, their behaviour does change. People generally aren't poor communicators because they're inherently poor communicators. There are other issues, they're too busy or whatever. And there are only a few that don't improve with constructive feedback, and they're the ones that we need to weed out. They're the ones that probably shouldn't be dealing with patients.
It comes back to, Norman, this issue of information. Sorry. What we found with the National Joint Replacement Registry is within 4 months, clinician behaviour changed because they got the information about what worked, what didn't work, how they rated compared to their peers. And they actually changed their behaviour. And after 12 months, they had significantly changed their behaviour. So it really comes back to getting information.
Yes, just brief.
Hello, everybody. I'm at the Ingham Institute for Applied Medical Research in Liverpool. Over the last 4 years, we set up a community cancer research panel from the community, which informs our research questions for dry and wet lab research in oncology. One of the comments we hear, or one of the learnings we hear all over the time has to deal with the who's the primary customer in our business. These community panel members, they hate the word consumer. They hate it. They're saying they're not going to Aldi to shop. They are community. And I think this is more than just a semantic difference between community and consumer. It has a kind of a different connotation how to deal.
I think I'm just going to leave that as a comment rather than asking the panel to comment, but I think it's useful to Peter Joseph.
Yeah, thanks, Norman. Peter Joseph, I'm on the board of the Black Dog Institute, FORE, and also the Health Science Alliance, a deep interest in all of this. Firstly, just to salute you all. I think the moral courage and the love and kindness that underpins everything that we've heard is just fantastic, and thank you. The other thing that causes me to reflect is the mere fact that we're having this kind of a conversation with so many diverse interests here in this room because of FORE, and which in itself is an alliance of people with like interests and wanting to improve the system, as Ian has commented on. Our job surely is to create an ecosystem that extends right through, and not simply for those with all good intentions are stressed out of their minds trying to look after the system. And I think that what you're showing us is a shared humanity that causes all of us to want to be good catalysts and enablers and to create structures. I'm not a doctor, I'm a boring business type, but we're not bad at creating models and structures which can, if you like, give evidence to what you're saying and create the ecosystem where we can stop just spinning the wheels. Thank you.
Thanks, Peter. And I'm going to have to leave it there, otherwise you'll not get any lunch, because we're going to start back here at 2 o'clock prompt, and people from the panel will be available for a conversation. Could you please join me in thanking them for being so welcome?